I will talk about AllonX later. For now, I think it would be more appropriate to share a few more ideas and focus on implant-assisted partial dentures. Ultimately, in cases where there is severe bone resorption in the posterior mandible, implants can only be placed in the anterior region, making implant-assisted partial dentures unavoidable. In other words, performing AllonX treatment using only anterior implants without placing fixtures in the posterior region results in excessive cantilever formation and compromises treatment stability. This is the edentulous classification system we learned in dental school, and it is quite simple. If both posterior regions are missing, it is classified as class 1. If the anterior region is missing, it is class 4. When only one posterior region is missing, it is class 2 or class 3. If a posterior abutment remains, it is class 3. Class V and class 6 are subdivisions derived from class 3. Class V includes an edentulous area involving the anterior region, while class 6 is limited to a posterior edentulous space. To summarize, when only one posterior edentulous area exists, it is either class 2 or class 3. If there is at least one posterior abutment tooth, it is class 3. If there is none, it is class 2. For actual clinical practice, it is sufficient to understand only classes 1 through IV. The remaining classifications are not very logical in my opinion. However, when analyzing partial edentulism, the Kennedy classification is essentially the only available system. That is why we have frequently used it when designing partial dentures. We have relied on this classification system. Implant treatment for partial edentulism can also be classified using the Kennedy system. Once the patient becomes completely edentulous, the Kennedy classification is no longer applicable, and treatment shifts to concepts such as AllonX or implant-assisted partial dentures. Therefore, it is sufficient to clearly understand classes 1 through IV. The two variation classes do not require much attention. Ultimately, the most important factors in removable denture or implant treatment are analyzing and diagnosing the quantity and quality of bone, as well as anatomical form. The presence of teeth and the growth and development of the jaw determine the anatomical bone structure. When periodontal disease occurs, the alveolar bone is resorbed. However, the basal bone of the jaw maintains its shape. In other words, when teeth are lost, bone is lost as well. If implants are placed during the process of alveolar bone resorption, the anatomical form of the remaining alveolar bone and basal bone must be analyzed, and fixture placement must be planned based on the quality and quantity of residual bone. Based on this, treatment plans for implant-assisted partial dentures or full dentures should be established. We must be able to understand this process. This classification illustrates the continuous bone loss that occurs after tooth loss. As you can see, the bone around the tooth disappears down to the root apex. However, bone beneath the tooth root does not resorb easily. Do you know why? It is because of the difference between alveolar bone and basal bone. In conclusion, alveolar bone exists only while teeth are present. In other words, once teeth are lost, alveolar bone is resorbed. From my long experience with implant treatment, I have observed that in most cases, at least 6 to 7 mm vertical bone remains. However, when removable dentures are used, more bone loss occurs. With removable dentures, bone tends to resorb further due to pressure and movement of the denture. In cases where removable dentures were not used, implants were almost always feasible. This is based on my personal experience. Therefore, when severe bone loss occurs, both removable dentures and implant treatment become more difficult. When anterior teeth are lost, bone resorption occurs in this manner. If you want to fabricate a screw-retained implant prosthesis, how should the fixtures be placed? When severe bone resorption has occurred, it is difficult to place implants according to the requirements of screw-retained prostheses. It is simply not feasible. If fixtures are placed according to the anatomical structure of the residual bone, the likelihood increases that angled stock abutments or custom abutments will be connected with abutment screws, and cement-retained prostheses will be required. Of course, screw-retained prostheses can be fabricated using angled multi-unit abutments. And when an open-type T-base abutment is used, it is also possible to fabricate a screw-retained implant prosthesis by fixing the abutment screw with an angled screwdriver through an angled screw channel. The reason I am discussing this is because the decision to fabricate an AllonX prosthesis as screw-retained or as cement-retained is determined by the position and angulation of fixture installation. In the early days of implant full-mouth rehabilitation, most prostheses were screw-retained, fully bone-anchored prostheses. It is also clinically feasible to fabricate screw-retained prostheses at the fixture level. Of course, fixtures must be placed with precise positioning and angulation to properly control the location of the retaining screw holes. In some cases, metal frameworks were fabricated at the fixture level to create fully bone-anchored prostheses. In this patient, metal capping was used for the premolar and molar regions, while porcelain denture teeth were used in the anterior region. In actual clinical practice, the simplest form of AllonX is a cement-retained prosthesis, similar to full mouth rehabilitation using prepared abutments. In other words, it is preferable to perform AllonX treatment with a cement-retained prosthesis using an implant system with a firm and stable abutment connection. In particular, connecting the abutments to the fixtures intraorally and fabricating the final prosthesis using a direct impression technique eliminates connection errors between implant components. Ultimately, by directly connecting prepared stock abutments or custom abutments to the fixtures and taking impressions using the direct technique to fabricate the working cast, accurate prosthetic restorations can be produced. It is essentially the same process as performing full mouth rehabilitation on natural teeth. And if necessary, implant prostheses can be fabricated using the SCRP concept, limited to the posterior region. Of course, screw-retained implant prostheses can be fabricated using angled multi-unit abutments or tie-base or custom abutments with angled screw channels. This approach is technically possible. However, due to inherent biomechanical limitations, performing AllonX treatment with cement-retained implant prostheses or using implant-assisted partial dentures is more advantageous for maintaining long-term treatment outcomes. To eliminate connection errors between implant components and fabricate abutments for AllonX or implant-assisted partial dentures using the direct impression technique, the abutment implant connection design is crucial. That is, fixtures should be placed according to the anatomical form of the residual bone, abutments should be connected accordingly, and cement-retained implant prosthetic treatment should be performed. When using cement-retained implant prostheses, there is always concern about abutment screw loosening. To reiterate, without an implant system that has a locking taper abutment connection, cement-retained implant prostheses are simply not feasible. When using a Morse taper screw-retained implant system, screw loosening tends to begin after approximately 5 years. In my experience, the stability of Morse taper screw-retained systems is about 5 years. After around 5 years, abutment screws tend to start loosening. Of course, in some cases, screw loosening occurs even earlier. Then screw retightening becomes necessary, and that becomes a serious problem. Because abutment screw loosening is a critical issue, screw-retained prostheses are often selected to allow repeated retightening of loosened screws. However, during the process of screw loosening, peri-implantitis can develop. Once screws loosen, many complications tend to follow. This directly leads to abutment screw fracture. It can also cause fracture of the fixture or the abutment. To fabricate a screw-retained implant prosthesis, a screw access hole must be formed on the lingual side. From an aesthetic perspective, screw access holes cannot be placed on the labial side in anterior implants. However, in many cases, it is not possible to place fixtures so that the screw access hole emerges on the lingual side. Based on bone resorption patterns after tooth loss, it is often impossible to place fixtures in that manner. In the mandible, however, it is relatively easier to place fixtures toward the lingual side. But in the mandible, there is a higher risk of failure during the initial stage of implant placement. When implants are placed immediately after extraction or into extraction sockets, fixture angulation often shifts toward the labial side. This can perforate the lingual bone plate of the mandible, increasing the risk of implant failure. However, patients indicated for AllonX typically already have significant alveolar bone resorption. Therefore, when fixtures are placed according to the shape of the residual bone, it becomes possible to fabricate implant prostheses with screw access holes naturally emerging on the lingual side. However, when the alveolar bone is completely resorbed, bone heating during drilling and perforation of the lingual bone plate may occur, right? In such cases, the long axis of the placed fixture tends to shift toward the lingual side. That actually makes screw-retained implant prostheses easier to fabricate. This is why AllonX is most commonly recommended for the mandible. The maxilla can often achieve functional restoration with a removable full denture. The maxillary bone is different from the mandibular bone. The maxilla develops through membranous ossification, whereas the mandible develops through cartilaginous ossification. This means that maxillary bone is weaker than mandibular bone. For this reason, maxillary AllonX has weaker bone support compared to mandibular AllonX. Additionally, depending on how much the maxillary AllonX overlaps the mandibular AllonX, overbite and overjet are established. If overbite increases and overjet decreases, lateral forces increase, resulting in excessive occlusal load on the maxillary AllonX. Ultimately, because it is difficult to secure tongue space and fabricate a stable full denture in the mandible, AllonX treatment is more advantageous. Another reason for preferring AllonX in the mandible rather than the maxilla lies in the bone resorption pattern. After tooth loss, maxillary arches tend to narrow, while mandibular arches tend to widen. As a result, performing AllonX in a narrowed maxilla requires covering the mandibular AllonX, which creates cantilevers. These cantilevers increase further as bone resorption progresses. In other words, as the size discrepancy between the maxillary and mandibular arches increases, cantilevers become longer, and the failure risk of maxillary AllonX also increases. Therefore, reducing overbite is necessary to minimize cantilever length. That is why eccentric guidance in AllonX is designed based on fully balanced occlusion. Even in cases with maxillary removable full dentures, occlusion is adjusted to a fully balanced scheme to ensure occlusal stability. Of course, in maximum intercuspation, stable contacts are achieved through interlocking holding cusps and uniform anterior tooth contact. I have also thought about this from another perspective. When two strong objects collide, repeated impact eventually causes one to fracture. But what happens when one side is weaker? The magnitude of impact does not continue to increase indefinitely. Why? Because function is adjusted based on the weaker side. When both arches are restored with fixed prostheses, occlusal force continues to increase. This is the concept of biodynamics in implant occlusion. Let me explain with an example. If the initial chewing force is about 1 when the prosthesis is first delivered, occlusal force continues to increase as the patient adapts to the new prosthesis. In some cases, occlusal force increases 3 to 4 times. This is why implant prosthetic treatment often remains stable during the first 1 to 2 years. However, after 4 to 5 years, occlusal force and occlusal load increase significantly. As a result, mechanical and biomechanical problems develop in the implant and surrounding tissues. When a removable denture is used in the maxilla or mandible, occlusal force increases initially but eventually plateaus. Think about it. If occlusal force continues to increase, the removable denture irritates the soft tissues and causes pain. Patients then come in complaining of pain in the tissues supporting the removable denture. At that point, I already know. I tell them that they probably tried to eat very hard foods or use the denture excessively. Because removable denture patients often come in complaining of pain in various areas. It is not because the removable denture does not fit. They may have been using the denture without problems for years. At that point, I explain the biodynamics of dental occlusion in an understandable way. For example, I explain that there is a functional limit to the force a removable denture can tolerate, and mastication must remain within that limit. I reassure them that I will adjust any high occlusion, but emphasize that they should not exceed the support limit of the removable denture. That is how I explain it. So when AllonX is performed on one arch and the removable denture is used on the opposing arch, occlusal force can exceed what the soft tissues can tolerate. Then problems inevitably occur on the removable denture side, right? However, cases with maxillary AllonX and mandibular removable dentures are relatively rare. They do exist, but they are not common. Typically, implants are placed in the mandible for AllonX, while a removable denture is used in the maxilla. But what happens when both arches are restored with fixed prostheses? How much does occlusal force increase? Patients with parafunctional habits such as bruxism or clenching, or those with inherently strong chewing forces, continue chewing until bone resorbs or implants fracture. Am I the only one who thinks this way? Ultimately, occlusal loads exceed the implant's support capacity, peri-implant bone is destroyed, retaining screws loosen, and eventually the implant fractures. That is how they come back to us. So the real question becomes this, and this is a very important point. Patients have a limited number of implants they can afford financially. Let's say their budget allows for 10 implants. No, let's say 8. 8 implants. What should we do with that? With 8 implants? Should we place 4 fixtures in the maxilla and 4 in the mandible and perform AllonX in both arches? Allon 4 in both arches? That would be suicidal treatment. Yet we see this frequently. On YouTube or at seminars, we often see cases claiming AllonX performed with 4 implants in the maxilla and 4 in the mandible. I wanted to understand why such absurd treatment protocols became popular. In many cases, clinics promoting AllonX operate together with dental laboratories. Prosthetic laboratory fees often account for nearly half of the total implant treatment cost. When patients pay for implant treatment, more than 30% often goes toward prosthesis fabrication. They charge high fees under the label of new technology. So implant companies and dental technicians appear to be gaslighting both patients and clinicians into promoting AllonX and Allon4. They claim that placing fewer fixtures makes prosthetic restoration easier. They also argue, absurdly, that placing fewer fixtures while charging higher fees maximizes profit. This logic is completely unreasonable, and it represents a very dangerous treatment protocol. Of course, in elderly patients with muscle atrophy, Allon4 may be feasible in some cases. But in healthy patients, the worst outcomes can be expected. Oral scanner companies also actively promote AllonX. They advertise that implant prostheses can be easily fabricated using intraoral scanning. They emphasize only the advantages of new technologies, including modelless techniques. They claim that everything can be done quickly and easily, but reality is different. To ensure prosthetic accuracy and verification, a working cast is still required, and with intraoral scanning, a 3D printer must be used. Ultimately, this places us in a situation where treatment precision and stability cannot be guaranteed. So what would I do in this situation? How do we ensure long-term implant treatment success? I would place implants in the mandible and use a removable denture in the maxilla. When a removable denture is used in the maxilla, the results of AllonX treatment can be maintained throughout the patient's lifetime. In fact, many of my AllonX patients are no longer followed up because many of them have already passed away. They use their prostheses until the very end of their lives. You understand what I mean, right? If the maxilla is restored with a removable denture, mandibular AllonX, whether Allon4 or Allon6, is acceptable. It is even better if masticatory muscle atrophy reduces chewing force. However, the minimum recommended number of implants is 8. Ideally, 8, 10, or even 12 to 14 implants should be placed in the mandible. Complete implant full mouth rehabilitation in the mandible is even better. With a removable denture in the maxilla, I believe patients can use both their implants and removable dentures without major problems for the rest of their lives. I honestly don't understand why patients are so reluctant to use removable dentures. In patients with reduced chewing force due to muscle aging, maxillary removable dentures combined with mandibular Allon4 or Allon6 are quite tolerable. If 8 to 10 implants are placed, patients can continue using them throughout their lives. If the mandible is restored with zirconia prostheses and the maxilla with a removable denture, no significant problems occur in the mandibular implant prostheses. What happens to the maxillary removable denture? It wears down. Severe occlusal wear occurs on the resin denture teeth in the maxilla. The mandible has zirconia while the maxilla has resin teeth. Wear of the resin teeth increases 2 to 4-fold. After 5 to 10 years, the maxillary removable denture can simply be remade. Then after another 5 to 10 years, it can be remade again. To prevent excessive wear of resin teeth, metal capping can also be applied to the occlusal surfaces. With this approach, patients can live their entire lives without significant aesthetic or functional dental problems. If you have experience with Allon4 or Allon6, you know that lip support is often insufficient. Lip support problems are particularly common in maxillary AllonX cases. Patients often complain of sunken perioral areas or increased wrinkles around the mouth. If zirconia is thickened to increase lip support, the prosthesis becomes significantly heavier. This excessive weight of zirconia implant prostheses can cause problems. Especially in maxillary AllonX cases, increased load is transmitted to the implant fixtures, creating additional stress. In other words, increased prosthesis weight due to gravity is transferred through the abutments to the implant fixtures and dissipated through the surrounding bone. However, when a removable denture is used in the maxilla, occlusal load distribution is not a major issue. Few clinicians discuss lip support problems in mandibular removable dentures or mandibular AllonX cases. When lip support decreases in the maxilla, patients often describe their face as appearing sunken. In that sense, removable dentures may actually provide better lip support. In my experience, cases treated with maxillary full dentures and mandibular AllonX have shown no significant problems.